Leprosy is a contagious disease, but many people are living or maybe living with it without knowing. And that's because the red patches or the reddish color on the skin, indicative of the possible start of leprosy, is painless, and its incubation period can last for about 20 years. Well, in a village somewhere in the central region, a traditional birth attendant who has the condition but not aware of has been conducting several deliveries. Seth Kwame Boateng is a producer of this documentary.
In the central region, we joined Dr. Benedict Quao and his team of experts in their case tracing mission, and this took us to a community called Isumanjura in the Bremane-Sikuma district. There, we met this 64-year-old traditional birth attendant, Abena Ahima. She has lived in this community for over 40 years. Abena has symptoms of leprosy, but she's not aware what it is.
Me kutia adibim me na ho ya me na yan ka poto na me bo mkoto edu bi me de bobo pa na ngwahwe ano so ai dan ai mama to ma adum te bibiduru na manuama no
na woni nurses and doctors think as on say dey be na yo
anu mo me de won wan kira yale pati ayam no what wo beble me edu
na wo hwa na ya we be na wan kasa woni
There's a
past injury.
Well, it is not surprising that Abena Ahima is not aware what she is battling with is leprosy. Dr. John Amuasi shockingly reveals just a few health professionals are able to even identify its symptoms and go ahead to treat.
For sure, medical doctors and nurses have been trained in leprosy. It's taught in the medical schools, in the nursing schools, midwifery schools, and in the allied health schools. But the question is, you may be taught something, but if it's not something you come into contact with on a regular basis, you will see it and you will not see it. All right? So because it's a disease that is not so common compared to other infectious diseases like malaria and typhoid and other non-communicable diseases like the hypertensions and the other cardiovascular diseases, it won't be the first point of call. In fact, most people will see it and think it is what we call tinea versicolor, or this disease that is caused by the fungus on the skin, because it presents exactly the same way.
Back to Abena, Dr. Quao and his team have identified some signs of leprosy, so they go ahead to examine her.
The thing is that if you lose sensation when you get injured, it means, or when you are likely to get injured, you cannot withdraw your feet to protect you from that injury because you don't feel. So I'm going to test to see whether there are any areas without that protective sensation. So I'll test at the tips here and then along the sides. What's in car? Now I want to when country why? What's in car? So this area.
Hi.
So you realize that the three, there was no sensation. It means that she can easily get injured here. So you understand why she has this ulcer here, because she can't feel here, 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 and here. So that protective sensation here is not there.
He then moves to her hand.
And in this case, she's lost the protective sensation on the hands. That's why she has this burn injury. She'll tell you that when she had it, she didn't feel the, but she realized that there was blisters there.
Yes, what they guessed is right. She has leprosy and has come into contact with many people here because of her job as a traditional birth attendant.
We are suspecting to have leprosy, has got very dry soles. And we know that when you lose those nerves that cause sweating, your soles can get very dry and they can crack easily and form wounds, ulcers. So you can see just by looking at her feet that it's very dry. If you touch it, you feel it.
Aside from the lack of sensation in her palm, fingertips, and some parts of her feet, there are also visible patches on her face and some parts of her body. There is also evidence of nerve enlargement.
So she can get the ulcer again because this area is not protected. The skin is, the sole is dry. It can get infected, it can affect the bones, the ulcer will continue, it won't heal. It can actually get much worse than this.
Seth Kwame Boateng joins me with more on this. Seth is joining me on Zoom. Hi, Seth. I'm also on Zoom with Dr. Benedict Quao. He is Programs Manager for National Leprosy Elimination Program at the Anchorford Hospital. Gentlemen, you're welcome to the show.
Thank you, Gifty.
So let me start with you, Seth. So you've been traveling not just to the central region, but you've been traveling across the country, tracking these people with this particular condition. How did you know that they were at risk?
The idea was not to find out whether they were at risk or not. The idea was to look at how they were being stigmatized. In the course of that, then I got to meet these people and I got to know more about their conditions. You know, when I came back from school, I had learned about stigma and how to deal with stigma. So my aim was to do something stigma related and how I can use the little knowledge I had acquired to fight stigma. So in the course of doing that, I managed to get these stories and they really helped in shaping up the story. And these are real issues, sickness that we have over the years relegated to the background because we think that we have completely dealt with.
Okay. Let me bring you in, Dr. Quao. So there's this perception that it's only a section of society, it's only a particular group of people who can or who are vulnerable to this particular disease. Help us understand the risks, you know, how are the risks in society? What are the things you do that necessarily opens you up to such a disease, for example?
Okay, thank you. The disease is spread by droplet transmission, and it is spread by the respiratory route through the nose, the mouth, and sometimes mucous membranes. Anybody that comes into contact with the droplets is potentially at risk. So irrespective of the age, males and females also have theoretically a 50-50 risk. So everybody is at risk. I always say that there's good news that 95% of the population will never get leprosy because of natural resistance.
Okay.
However, there's currently no way of telling who fits within the 5% group and the 95% group. So it means that we are all potentially at risk of developing leprosy.
So, but for people who have the disease, isn't there a particular trend or pattern, that we can follow to make such a prediction? So, say you can say people between the ages of 50 and 70, people within the ages of 20 and 30, or people, I get the female and the male, the gender-based, 50-50, that's fair enough. But isn't there any prevailing pattern that we can learn from to be able to make a prediction?
Okay, so in Ghana, we have slightly more males affected than, I would say slightly more males detected than females, although we know there's a theoretical 50-50 risk. And sometimes we tend to think that it is because maybe females have less access to the health system. We also have noted what is like a bimodal distribution. that you have a number of people just in the late teens, and then you have another peak around the 30, 40 age group. It doesn't mean that those people are at a higher risk. We are talking about a disease that has a long incubation period, which can span up to 20 years. So we have to have that in mind. It just tells you that the infecting event would have occurred anything between 2 to 5 years averagely, but possibly spreading up to 20 years before you get the case.
Is this hereditary?
No, it's not hereditary. This is one of the areas that has been a source of stigma. When someone has leprosy, their family members tend to be shunned by society. But for a disease that is spread by droplet transmission, you agree with me that someone living in the same house, someone eating from the same plate, someone sharing the same roof is likely to get infected. And so it tends to run in families, not because it is genetic, not because it is hereditary, but because people that are in close contact for a long time are likely to get the disease transmitted to them.
Wow. I didn't know actually that there was a national leprosy elimination program, and I'll come to that. But in our quest to tell people that it is not good to stigmatize, sometimes we want to, you see politicians, for example, shaking hands with people, you know, who have been infected or people who have the disease, etc. Is that dangerous?
No, as long as the patient has completed the course of treatment, they are not infectious. In fact, the moment they start taking the MDT, the drug that is available, the very first tablet they take kills about 99.9% of the bacteria. And so that patient is considered non-infectious. And that is why we no longer segregate patients who have leprosy. They come and take their drugs just like people take their antihypertensives, anti-diabetic medications. So usually those you see are those that are having the sequelae, the disability due to the illness. The illness is gone, but they are suffering the pain and the despair of the disability that the illness brought. And sadly, when we add on the stigma, then we continue to inflict more pain on these wonderful brothers and sisters of ours who, through no fault of theirs, got infected with leprosy.
But the National Leprosy Elimination Program, I didn't know we had a program like that. Bring us up to speed. Help us understand. For people like me, what really are you supposed to do, and what have you done so far?
So the National Leprosy Elimination Program or Control Program is within Ghana Health Service. It's within the Public Health Division of Ghana Health Service. And there are several programs that deal with different diseases. Some are more popular, like a National Malaria Control Program, AIDS Control Program. The leprosy program started as the Ghana Leprosy Service as far back as the 1950s. And it is due to the work of the Ghana Leprosy Service, which became the National Leprosy Control Program, that we were able to eliminate leprosy as a public health problem. So this has been identified by the Health Service. It is just that after we eliminated it as a public health problem, as happens with many diseases, you've dealt with the problem. And so now we tend to focus more on other diseases with maybe a higher burden. It doesn't mean that the disease is not important. We have some new cases that develop. We have to find them early. We have to ensure that we treat them, and we have to ensure that we get to zero. The problem with leprosy is that the world assumed that when we attain this elimination target, within a few years, we'll get to zero. But if you look at global leprosy figures, we've been recording about 200,000 new cases of leprosy every year for the past 15 years or more. So the whole world knows that leprosy is still there. It is not a problem peculiar to Ghana. Ghana has done very well. Our case numbers have come down. They have continued to go down. Our prevalence rate is now 0.1 per 10,000, which is far below the threshold of 1 per 10,000. But we need to be able to find every case early. Otherwise, they will transmit it before we find them. And then sadly, they may have developed disability before we find them if we do not detect them early. And that is why Ghana Health Service has not collapsed the leprosy program. We still work. It is just that we are not as visible as the other bigger programs or other diseases which have a higher burden in our society.
Fair enough. I'll take my final question with you and then I bring Seth in. But whilst you do that, hang on for me. I just want you to tell us what are the areas of improvement. I mean, what is it that we can do? You've indicated that it seems like you've achieved, a very significant part of your goals. But what going forward can we do? Seth, I'm coming to you so that you highlight that for me, and then I'll get Dr. Okay, we've lost Seth on the line. But Doc, let me just wrap up with you. Tell us, going forward.
We need to find cases earlier. I want to answer your question. We need to find cases earlier. So we need to sensitize both the public, and this documentary has done a lot in that regard. We need to train more of our healthcare workers. And then there is a form of active case searches. When you go out into the community and look for cases amongst people who are apparently healthy. Now in leprosy, we do that amongst contacts. So that is one area that we are strengthening in the program. And WHO has just released a guidance that's a little over a year ago that now we can give contacts of leprosy patients a drug that will reduce the risk of leprosy by 60%. Okay. So we are in the process of working to implement that also. Once we can do that, coupled with the increased sensitization and training of our healthcare workers, we can be able to get to the end of leprosy. It is possible. At least by 2030, we should get there.
I'm hoping that we'll get there. It actually has interesting characteristics like coronavirus, I must say. Something that has to be...
It does.
Yeah,
it does.
It's contagious, it's through droplets.
Yes.
You have to be contact traced. It's interesting, pretty interesting. But Doc, thank you so much for your time and for the work that you do at the hospital. Dr. Benedict Quao is a programs manager for the National Leprosy Elimination Program at the Ankafo Hospital, joining us there. Earlier, I had Seth Kwame Boateng join me also. He is the producer for that documentary.